Hello, welcome once more. Today we are going to discuss wound healing and wound care in traumatic patients and in surgical patients. Our learning outline will be definition of wound, that is surgical wounds, stages of wound healing, wound assessment and classification, wound management, specific wound management, and we shall end with wound complications. A wound is a break in the normal continuity of a tissue. A tissue can be a skin, a peripheral organ, a visceral organ. As long as there is a break in the continuity of the skin or surface of that tissue, it is defined as a wound. Wound healing occurs in three major stages following injury. That is the coagulation phase, the inflammatory phase, and the proliferative phase. In the coagulation phase, vasoconstriction, coagulation, and release of clotting factors and platelets happens, and this is aimed at cutting off bleeding and ensuring that there is no more blood loss. This is part of the body physiological mechanism in response to injury. Then in the inflammatory phase, that's when we have leukocytosis. There is vasodilation and exudation, leukocytosis, and then migration of inflammatory cells. This is majorly important in the killing and destruction of all possible microorganisms that could have invaded an injured tissue. And in addition to that, it is also important in initiating inflammation that would help in wound healing and recovery. In this phase, also rapid epithelialization takes place, and inflammatory phase takes up to 3 days following injury. The last phase, which is proliferative phase, there is fibroblast proliferation, epithelial cell proliferation, there's endothelial cell proliferation, collagen synthesis, and angiogenesis, and this takes up to 3 weeks. And in this phase, it's where the injured tissue is beginning to grow and close off the injured surface. And then lastly, which is the maturation phase, this is the phase of remodeling, and it involves a balance between destruction and build-up of new tissues. And the major growth component involved is the collagen, growth of the collagen bundles, elongation, and increased tissue strength. And this is aimed at replacing the recovered, the injured part or a wound. And this phase, the maturation phase, it can extend even up to 1 year. Clinically, wounds are classified based on their healing stages or based on their mechanism of healing. Some wounds heal by primary intention, other wounds heal by secondary intention, and other wounds heal by tertiary intention. Healing by primary intention, a wound is closed immediately after it has been cleaned, and the edges are approximated and the wound is sutured. And wound healing occurs by epithelialization, and the scar is always left behind. On the other hand, healing by secondary intention, a wound is not closed primarily. It's just cleaned but not sutured or closed. And healing takes place by granulation tissue contraction and epithelialization. And it is often used in contaminated wounds or in wide wounds. Healing by tertiary intention, it's where the wound is left open at first, and then after thorough evaluation and observation, for progress and recovery and no risk of sepsis, then the wound can be closed later on, and this is also known as delayed primary intention. There are various factors that affect wound healing, i.e. factors that slow down wound healing, and they may include ischemia and decreased oxygen perfusion, presence of foreign bodies, closure and tension. That is when tension features are used for closing off the wound. This could also slow down the process of wound healing. Infection, there is irradiation, presence of systemic illnesses like diabetes, renal failure, malignance, diabetes, Poor nutrition status, as you know, nutrition is very vital in production of immunoglobulins and inflammatory mediators such as protein-based inflammatory mediators and immunoglobulins, which are very important, vital in wound healing. Immunosuppression and chronic infections, drugs such as corticosteroids and cytotoxic drugs, all these can impede with proper wound healing. Wound assessment. If a patient presents you with a wound is assessed through proper history taking and proper wound examination. And this can also be followed by relevant investigations as you seek out for the management plan for a given wound. History taking, you ask about important questions that could help you in diagnosing and determining the cause of the wound, the extent of tissue damage, and the extent of neighboring neurovascular and bundle damage. In history taking, you seek out to know what caused the wound, mechanism of injury, at what time did it happen, from the time of observation, the time of occurrence. Then you also seek out what caused the wound and patient's relevant past medical history that may interfere with wound healing, such as diabetes, presence of underlying chronic illnesses, immunosuppression, use of corticosteroids, malignancies. You ask about those long-standing illnesses or underlying illnesses that could impede with proper wound recovery. On physical examination, you assess for the extent of skin loss. You assess for the degree of saturation if the wound is in close proximity with neurovascular supply. And in addition to that, you assess the rate of blood loss if the wound is still bleeding. You assess for damage to the nerves, tendons, bones, and other structures, degree of contamination, and even presence of foreign bodies, or even if there is already tissue necrosis in the wounded or injured area. So wound generally on appearance can be classified into open or closed wound. A closed wound is when the skin is intact, but there is underlying tissue damage. And examples can be contusions, bruises, and hematomas. Then in an open wound, of course, there is a complete break of the epithelial protective surface or the skin, and as a result, there is exposure of underlying tissues. Examples can include abrasions, lacerations, punctures, missile injuries, and bites. We can also classify wounds based on degree of contamination, as this is important and guides on the risk of sepsis and the risk of infection spread from or wound infection. So this classification is always used to determine whether a wound is at high risk of being infected and sepsis, or if a wound is at a low risk of being septic and infected. A clean wound is a non-traumatic, non-infected wound. There is no break in sterility technique. The respiratory and GIT and genitourinary tracts are not entered. Examples of such wounds can include a wound secondary to hernia repair, herniorrhaphy, where you find there is no entrance into the gastrointestinal system, respiratory system, and in addition to that, there is no break in a sterile technique. That is a clean wound. On the other hand, a clean contaminated wound, it's where there is a minor break in the technique of sterility, and there is maybe breach into the oropharynx, GIT, or respiratory tracts, but there is no significant spillage. Genitourinary system and bile tracts are entered in absence of infected urine or bile. That is a clean contaminated wound. An example could be appendectomy, where you're managing appendicitis. A contaminated wound is a fresh traumatic wound with major breaks in sterility. There is gross spillage of gastrointestinal tract, and there is entrance of genitourinary or biliary tracts in presence of infected urine and bile. While lastly, a dirty and infected wound It's where there is acute bacterial inflammation without pus, the wound with heavy contamination and evidence of infection, and then there is traumatic wound with retained devitalized tissue, foreign bodies, fecal contamination, or delayed treatment. And also the wound could be from dirty sources, e.g., for example, bites. All those are dirty and infected wounds. So how do we manage wounds? Generally, these are what should be considered when you're managing wound. First of all, in managing wounds, care should be taken not to overlook other life-threatening conditions, and you start concentrating on even less important things. For example, a patient might be having a mild trauma or trauma to the internal organs, and is just presenting with a minor superficial skin injury or wound, and you focus too much time or too much emphasis on that superficial skin injury, and yet the patient is actually having internal hemorrhage and is at a risk of dying in a few minutes to come. So it's important to first evaluate the patient head to toe, so using primary and secondary service, and when you're done, it's when you can focus on local management of the wound that has been observed. And it is advisable that in order to save a patient's life, you just you cover the wound with a sterile gauze, and then from there you can go for primary and secondary surveys to assess if the general health or general well-being of a patient head to toe is okay. Under the primary survey, of course, we assess for exsanguination, if the patient is having any signs of severe bleeding, and then you assess their airway if it is patent, if there could be issues to do with tension pneumothorax, if there could be issues to do with obstruction, if there could be issues to do of the airway, if there could be issues to do with obstruction, of course, as it can be either solid or it can be fluid aspiration. All those you just assess and see whether the patient is able to maintain a patent airway and is able to produce sounds. And then for breathing, you assess for the respiratory rate, you assess for the patient if the patient is having features of breathlessness, if the patient is gasping for air, and you can easily know whether we are dealing with tension pneumothorax, whether we are dealing with aspiration, whether we are doing, so that we ensure that the patient's airway is patent before we can progress. Saturation, blood pressure, pulse. You can also assess for the degree of blood pressure, the saturation, the pulse rate, and then in addition to that, you can assess for the extremities. You just ensure that your patient is not in shock and your patient is doing fine. If the patient is showing features of hypotension and shock, then there could be need of IV fluids administration or even blood transfusion. You also assess for disability, that is a neurological disability, and that is always assessed through performing a CNS exam and doing a GCS score, and you assess whether the patient is fully conscious or if the patient is already unconscious and their GS score is low and non-promising. In secondary survey, you expose the patient head to toe and examine the head to toe. You ensure that the patient environment is safe and the patient can fully recover. The patient is kept in a warm environment, and then you take full history, and then after that, all that has been done, you can go further and assess the wound and soft tissue injury in detail. So the major emphasis is that before you focus on the wound, it's important to first assess the patient head to toe, do thorough history taking, and then from there you go back and focus on the wound that has been presented to you. This means that when the patient presents with the wound, you have to first maybe cover it with a sterile gauze, and then you ensure that it is not bleeding, and then you can focus on other systems before you go back to continuous and final management of the wound. So generally, proper wound care should include the following measures. There should be adequate hemostasis locally to stop bleeding, as we have just finished saying. There should be adequate irrigation to reduce bacterial load and foreign particles, and then the wound should be debrided carefully to remove all dead tissues and non-vascularized fragments. And then, having done all this, the doctor should make a careful decision on whether to close or leave the wound open. And this should be based on the degree of contamination and the extent of the wound. To know if this wound should be closed by primary intention, if the wound should be left healed by secondary intention, or if the wound should be left healed by tertiary intention. And in addition to that, supplementary antibiotics and tetanus prophylaxis as required should be administered. And in case of any underlying systemic illnesses, the systemic illness should be managed in order to improve host response and wound healing rate. So general guidelines for wound closure, as we had just discussed, clean wounds should be closed primarily. Clean contaminated wounds can be primarily closed if they can be converted into clean wounds. Untied or contaminated wounds which cannot be converted to tied wounds should not be closed primarily. They should be left to heal by secondary intention. And all major wounds, animal and human bites, should never be primarily closed unless strongly indicated. From there, we are going to discuss about types of wound closure. As we had discussed, a wound closure is either by primary closure, secondary closure, or tertiary closure. And primary closure is effective in wounds presenting within 6 to 8 hours and can be accurately debrided. And then after that, they can then be sutured off and closed. And this is always common in civilian practice or in our communities. While delayed primary closure is done for traumatic or contaminated wounds to avoid the risk of sepsis. The wound is initially left open, and then after 3 days of initial treatment, then the wound can be closed. Then, on the other hand, secondary closure, this is usually done in 3 to 7 days of initial treatment. It is effected in contaminated or traumatic wounds. It provides reliable drainage and opportunity for repeated inspection and debridement if necessary for the wound. It should be remembered that different types of wounds have specific management, and different types wound management is always governed by the specific local wound factors: the location of the wound, the type of the wound, and even the extent of tissue damage caused by the wound. And in common types of wounds that are always experienced clinically include bruises, hematomas, abrasions, punctures, lacerations, crash and avulsion wounds, missile injuries, and bites. So we are going to discuss briefly about how specific type of wounds can be managed in addition to the general consideration we have just discussed. For example, bruises are always superficial, and they are not so severe or dangerous as such. So there is no specific management except that it is recommended you give analgesics to reduce on pain, and local compression may also be advised to also help in reduction of pain. Our second type of wounds is hematomas. This is a collection of extravasated blood in soft tissues, and there is no specific management as such because blood is usually absorbed spontaneously, and so there's no need for any intervention. However, local compression can also be done to alleviate pain, and in some cases, aseptic evacuation is recommended in case the wound is expanding, or if the hematoma has been formed over a cosmetic area and it is leading to compression of vital structures. For example, hematoma has been formed on the face and the patient is uncomfortable with it, it can be evacuated. Or in other cases, if the hematoma is compressing surrounding structures that are vital for the functionality of the body, it can also be evacuated. An abrasion, which is another type of wound, is rubbing or scraping of skin or mucous membrane, and this is always seconded to a frictional contact between a skin and a rough surface. and it may affect only a part of, or a layer of, it may affect part of the skin layers, or it can affect all the skin layer. And in most cases, data particles can be observed to be embedded in under the skin defect. And the general management for an abrasion, you clean the affected site, that is debridement, with running water, and if possible with a brush, to remove all the embedded particles and dirt in the wound. Then you use antiseptic or lean tap water and soap to support and assist in the cleaning. In addition to that, you can give pain analgesics to help in management of pain. Our first type of wounds are punctures, and these are always wounds that involve deeper structures, and they require careful management. Why? Because most of times the injuring devices, it could be a knife, it could be a bullet, it could be any deep cut, are always even left intact or left in deep in the injured tissues. And in addition to that, these punctures always cause deep tissue damage that is even severe than what is being observed. Management may include evaluation of the depth of damage, and then you remove the pricking or other foreign bodies. If the knife has been left in, you remove it gently, and the proper techniques should be followed in order to remove minus causing severe hemorrhage. And then you excise the damaged tissue, you give antibiotics, and tetanus prophylaxis is also given in this case. Lacerations are open wounds caused by an object moving across the skin, commonly caused by sharp and thin objects which slice through the with minimal energy, like a knife, a glass, but can also be due to high energy impact, maybe secondary to a bullet. Management is through careful inspection of the wound, adequate cleaning, and then closure if feasible, and appropriate anesthesia, and proper wound debridement if needed is also recommended. Then antibiotic prophylaxis, that is encouraged, and then tetanus prophylaxis and administration of analgesics is also encouraged. Our next type of wound is crush and avulsion wounds. These are compound complicated wounds. They are always secondary to trauma, and they are always associated with severe systemic involvement and have more extensive damage to the underlying structures than what may be observed, or what may be observed at the periphery or at the surface. Their management, you first collect the underlying life-threatening conditions, and you stabilize the patient's vital signs. These crush and avulsion injuries are always accompanied with polytraumatic injury to other tissues, and the very first key thing you do is do a primary and secondary survey, as we just discussed. Collect the vitals and ensure the patient is safe, and then from there you can inspect your wound carefully. You do wound debridement, and then administer adequate antibiotics, tetanus prophylaxis, analgesics for pain management. And these wounds are not always closed by primary closure, so they are always left open until they are observed to be recovering thoroughly. Another type of wounds are bites, and these are either human or animal bites, and most of these wounds are always contaminated. The human bites are very rare, but in case they happen, they are all very contaminated, and because of presence of the polymicrobial organisms in the oral cavity, some of them which are normal flora, and they include both the aerobic and anaerobic. These, in case of a bite occurs, these microorganisms are introduced at the site of a bite and may cause severe injury and infection of a bitten part. And management of human bites, it is careful wound inspection. Then from there, a culture is taken from the wound site a sample is taken from the wound site to do culture and sensitivity, and to know what are the major causative agents in the given site and to plan on how to treat them. And then from there, thorough scrubbing and liberal irrigation with saline or plain water is encouraged in order to remove or to reduce on the load of the microorganisms that could be yet to cause infection. And adequate debridement, you remove the necrotic tissue as you clean, and you ensure that the wound is fresh and bleeding. And then the wound is left open except if it is in anal face or head wounds. If maybe a bite was made on the face or head, maybe closure can be encouraged. But if not, the wound should be left open and should not be sutured with tension to shut with tension to sutures at all. And in addition to that, in case there is injury of tendons and nerves, these structures should not be sutured primarily. Broad spectrum antibiotics should be introduced as culture and sensitivity is done to know the exact causative agent before you can give specific antibiotics to manage the underlying microorganisms. Tetanus prophylaxis is given, and the wound is continuously observed to look out for any complications or progression and to assess whether the wound is recovering as expected. Another type of wounds are the dog bites. Dog bites are always associated with spread of rabies virus, and they are always, if not early managed, they can even progress to very severe states and even can cause death. And most of the times, dog bites are always caused by bite from infected dogs, which are always infected with rabies virus. And to avoid complication of progression into rabies disease, the animal that has caused the bite must be kept under observation for at least 10 days, and at least even the causative animal, the dog, should also be treated for the possibility of having rabies disease. The wound second dog bites should be urgently managed and treated, and their management can involve both local management and systemic management. In local management, vigorous irrigation and repeated swabbing and flushing with soap and water or antiseptic is encouraged. And in addition to that, a local anti-rabies serum infiltration under the wound is, if available, should be made, and the wound should be left open. The wound should be continuously cleaned, debrided, and local anti-rabies serum should be infiltrated under the wound to kill the possible rabies virus. And in addition to that, under systemic management, post-exposure anti-rabies prophylaxis, that is 1 ml intramuscular, should be given on the 1st, 3rd, 7th, 14th, and 28th days following the bite. And tetanus prophylaxis should also be administered in addition to other antibiotics to prevent the risk of sepsis. Another type of bites are the snake bites, and most bites can be either from poisonous or non-poisonous snakes. Non-poisonous snake bites do not cause severe systemic injuries apart from local wound infections, but poisonous snake bites are associated with severe complications and can even risk to death. So, in the case of a snake bite, immediate aggressive measures should be taken to limit these effects. The first aid for snake bite in periphery before you reach the hospital setting, in a village or in a community outside the hospital setting, the local wound of a bite should be irrigated with running water, and a pressure bandage should be applied proximally to the site of bite, but the care should be taken not to completely occlude blood saturation for more than 2 hours. So the pressure bandage should be applied for less than 2 hours, and within 2 hours time the patient should be taken to the hospital, and then caution and further management should be done. But if it's not possible, then proper caution should be taken, because occlusion of blood supply to the damaged limb or injured limb for more than 2 hours may be associated with ischemia, necrosis, and it could end up with loss of the entire limb. Immobilize the limb to minimize venom absorption, and the patient's limb or the limb that has been bitten by a snake should be immobilized and kept in one position to reduce on the rate of saturation and minimize the absorption and spread of the venom. And as we have just said, the patient should be immediately transported to the nearby hospital for further management. In the hospital setting, the management includes identification of the species. The physician can easily identify through observing the types of bite and the fangs on the skin surface, and then necessary laboratory investigations like hemoglobin levels, renal function tests, coagulation profile should be observed, and to look out for any derangement, and antivenom injections, if available, should be given, and supportive care for severe conditions, that is, in case complications are developing second with the bites, they should be managed, and patient rest should be encouraged. IV fluid should be infused in case shock is suspected, or even there should be continuous infusion of IV fluids to combat shock. Prophylactic antibiotics should be administered to reduce the risk of local wound infection and sepsis. And tetanus prophylaxis should also be given to reduce the risk of infection with tetanus. And if local complications are progressing and worsening, surgery may be recommended to manage the complications, and wound excision may be done. Fasciotomy, in case there is development of compartment syndrome, should be done to prevent and manage the compartment syndrome. From there, we are going to discuss briefly about the common wound complications and how they can be managed. It should be observed that improperly managed wounds can result in variants from normal healing and become complicated, resulting in local systemic complications, sepsis, and infection. Common local complications include hematoma formation, seroma, infection, dehiscence, granuloma formation, scar formation, contracture formation, and this can lead to loss of joint function. On the other hand, systemic wound complications may include death in case sepsis has developed and there is severe hemorrhage. More so, systemic manifestation of hemorrhagic shock due to massive bleeding may also occur. Bacteremia and sepsis from a source of locally infected wound may also develop. Generally, this wound should be properly managed and followed up to prevent the risk of progression into complication states, because a complicated wound may affect the well-being of a patient. It may cause death, and or even it may cause loss of function of the entire limb, and which as a doctor or physician would not wish progression into such a states. Thank you for giving me your attention. Good luck. I hope to see you soon till we meet again.